And the answer is that's probably the floor. That the NCQA level 3 is probably the floor. That's the minimum that you need. But as Bob Graham in Cincinnati constantly reminds us, you need the culture of a medical home to lay in on top of that. And that culture is a culture that spans across the providers as well as the health plans. It really requires, especially the physicians, to understand what the team practice of medicine is all about. And every doctor in the room will tell you that that's not something we get trained in when we go through medical school and residency. Team is not a part of it. It is something that we do. We are individuals and we all have our own best practice, if you will. And we all think we have our best practice. But I do think that it is something that we're learning, that you know what we know and what we've been taught doesn't necessarily always translate into the actual translation to the patient. And that's really where I think the opportunity lies. The data, the information is all important. A couple of lessons learned from the pilot in Cincinnati have been that physicians love it. The physicians who are in it really love it. They say, I'm actually starting to do what I was trained to do, and I enjoy doing it. I enjoy coming to work every day now. The other thing is that they actually have, because remember, fee-for-service doesn't go away under the medical home model. We just layer coordination of care on top of it. But because of the improved access, they actually saw their productivity go up about 20%. So they end up having this kind of awakening, like, oh, there is life at the end of the tunnel here, and that we can make some difference in the way in which medicine is practiced in primary care. Been participating in the meetings, and I think Cleveland is well on their way. In fact, ahead of us in many ways in the Cleveland market with regard to especially data.
So I hear both local health plan, national health plans saying that they are supportive of this kind of care transformation, but there's got to be more of a focus on outcomes, not just on structure and accreditation, et cetera. So that's the health plan side. So other stakeholders. So Tim, major employer and doing some very innovative things. What have you been up to, and what's your perspective on it?
Well, our perspective is a little bit different, and again, I can speak to the journey that corporations have had in this space. I mean, in the past, I think corporations just purchased it as any other commodity and said, we'll leave this up to the health plans and the providers to provide care and do the right thing. Then we started staring at astronomical inflation with poor outcomes and started doing things differently. So at Progressive, we've taken a stance of having really 4 pillars of how we look at this. We have a well-developed metrics that basically Harold was alluding to in terms of cost, disease states, quality, customer satisfaction. That's from our claims data as well as some other data that we have access to. So the first piece is to understand where you're at so you can understand where you're going, and that for us is well developed within Progressive, and it should come as no surprise being an analytical organization. The second piece pillar we're going to is this culture of health that you hear about. We subcategorize that into 2 areas. One is the corporate culture of health. We've just recently moved our food vendor out for Healthy Choices. We provide a lot of wellness programs, fitness programs. We're actually moving towards the changing the individual as well for incenting them for healthy behavior, and with that, the corollary, disincenting them for less healthy behavior. So that journey is well underway. The third lever is probably the most lever that has the greatest impact on our population, which is plan design. And we've been migrating from a very old model of an EPO towards one that's going to really have our employees, associates, have skin in the game with the tools that they can make right decisions and go along the right path. And so clearly plan design and loaded with incentives and a lot of value-based plan design will assist them. And then the fourth piece is the piece that really speaks to what we're here today about, which is a thing that I've sort of termed care efficiency. Being a physician, having practiced medicine for many years, healthcare is anything but efficient. Healthcare is everything but, including fragmentation. It's very dissatisfying from my perspective to see what is delivered, how it's delivered, and how poorly it's done. And care coordination is a key thing that needs to be improved. And so along the lines of care efficiency, I blame ourselves as purchasers for creating this, because we have had the incentives for years to just pay cost plus reimbursement. We've had the incentives for years to pay for treatment of incidence of disease, when in reality what we want is value and we want outcome. So as has been alluded to earlier, I could personally care less whether people are, NCQA level 3 accredited for medical home. I view that as a tool to a movement towards good outcomes. But what I'm interested in doing is changing our incentives to moving towards facilitating people to achieve those outcomes. In healthcare, only 3% of the dollars spent is related to quality. 97% is purely spent on transactional things of, I came in, I had a hip done, I went out, we're paying you for it. Not about the outcome whatsoever. So I'm keenly aware and keenly interested in changing what we pay for to get the right outcome. I'm a firm believer that if you don't change the incentives, you're going to get the same outcome all along the way. And so we're looking at a variety of value-based entities to occur. We're actually looking at medical tourism within the United States for certain procedures. We're looking at value-based plan designs from our pharmacy end. We're looking at participating in bringing together the various constituents to make patient-centered medical home a reality in the Cleveland area, because I truly believe with the Geisinger experience that was alluded to that will be useful. We're looking for paying for electronic visits. We have health clinics throughout the country at Progressive that account for 25% of the primary care of our folks, and we've been doing virtual e-visits for years. So, we need to make that a reality, because if you're a person that has allergy and you come in, in a year and your allergies are acting up again, why do you need to visit the office? Renew the med, let's have at it, nothing's changed. So again, we've done a lot of things, we're in the space, we're going to take a much more active role, and certainly it's caught the eye of the exec suite simply because of the cost structure. When you look over the last decade, salaries have gone up 3%, inflation is 2.2%, healthcare is 119%. Fortunately for me, Progressive's not in a legacy organization, it's manufacturing where the profits are strangled, and we're not going to see the demise that the auto companies had in Detroit, given what they had. But we're trying to be proactive in that space and trying to curve all this. So, I'm happy to be here and representing Progressive, as well as the Health Action Council and the Purchasing Coalition, and we're here to share the stage and hopefully coordinate, facilitate, and influence perhaps the direction of the plans as well as the provider organization.
Great, thanks. So Jim, last but not least, you're trying to make this work in one of the more challenging settings is without payers in many cases. So what's your experience with that, and where do you see things going?
Okay. Well, Metro Health is the public health and hospital system in Cuyahoga County. We're celebrating our 175th anniversary this year, if I'm not mistaken. And I think for many of us who work there, we see ourselves not just as a hospital, but we see ourselves as stewards of a real community resource and the community treasure. And I think many of us approach our work with that in mind. Back in 2008, our senior leadership started to look at both the growing numbers of the uninsured and the growing costs of their care. And we asked ourselves, how can we start to provide care for the people who need it most in a way that's both more clinically effective for the patient and potentially more cost effective for the system? And through that conversation, and with the leadership of many of my colleagues in the primary care physician community, we decided to implement a patient-centered medical home model of care specifically for our uninsured population. And even though trying to do this in a force field of misaligned incentives is very difficult, with the uninsured, the incentives were aligned. We both provided their care and paid for their care. So what we chose to do was invest in our primary care practices in three ways. Number one, we tried to improve the processes of care, establish better access, establish more efficient processes. Number two, we established care teams that involve physicians, advanced practice nurses, the rest of the nursing staff, as well as nutritionists, social workers, and mental health professionals where we could. And number three, we embodied care coordination for our highest risk uninsured in the person of a care coordinator. We hired nurses with case management experience to work at our primary care sites. We embedded them in the primary care sites and asked them to interact with the highest risk patients in the uninsured populations at those sites. We gave them EMR-based registries. Metro is fully integrated in the Epic EMR, so we were able to leverage that technology to produce registries around chronic illnesses, around high utilization, and we asked our care coordinators to work off of those registries to help establish relationships with patients to sort of help them solve whatever problems they were facing in improving their care. And what we have found also, that's sort of the care delivery side, but we also enveloped that in a care management infrastructure where we looked at referral patterns. We asked uninsured folks who previously had unlimited access to specialty care to get a referral from a primary care physician first. So we tried to build a care management infrastructure around primary care as well as improve what we do at the primary care level. And what we found so far has been very encouraging. We are seeing increased primary care utilization. We're seeing decreased ED visits, decreased hospitalizations, some decrease in costs, as well as improved health outcomes specifically around diabetes and hypertension. So the indicators at this point are moving in the right direction. I think one of the big challenges for us to implement this system-wide with all of our patients, frankly, is that the kind of services we know we add value simply aren't being paid for right now. And you add to that the fact that there's been a historic underinvestment in primary care in the U.S. healthcare system. I think I read recently that primary care accounts for 9% of total healthcare expenditures in the United States. I mean, if you compare that to other countries that invest in their primary care systems and get better health outcomes, it's really an underinvestment that's going to need to be addressed at the primary care level through whatever mechanism of payment reform we choose to pursue.
So it's interesting, what you're describing is you're actually being paid on a global payment model.
Yes.
Right?
Yes.
You're paying zero, but it's a global payment, which gives you the complete flexibility to decide, what to do within it,
exactly.
and you can reinvent care on that basis.
Exactly. And I think some of the really premier PCMH demonstration projects like Group Health in Seattle have that payment system that wraps around it. And so they're really able to align the incentives as opposed to working in what I continue to call the force field of misaligned incentives.
Right. So we only have a couple minutes, so I just want to ask a question that really relates to sort of what the purpose of today is, which is, can the community come together and jointly invent the future? And this raises some really serious issues for a lot of communities about competition versus collaboration. Can you actually get things to move in the right direction? So let me ask our friends from the health plans first. So should health plans be competing on different payment models, or can they actually come together to agree on having the same payment model to enable health care providers to transform?
He gets to go first this time?
You can sort of bribe each other to see who'll pay more to have the other go first.
It's a great question, and Cleveland in particular is Medical Mutual's home, and I've been on the leadership team with Better Health Greater Cleveland since its inception, and we, as most large companies do have a strong sense of community and recognize that as Cleveland goes, we go. It's very important, and we're very committed from our corporate objective as well as our business objective and what our contract is with our customers to improve the health of Cleveland. And Better Health Greater Cleveland has a leg up over all the other Robert Wood Johnson communities in that we are already collecting EMR data and reporting it, and the degree of transparency that we have in Cleveland is something that we should be really proud of. All the other initiatives are claims-driven initiatives, and I think that the next step for us to maintain our leadership, Better Health Greater Cleveland leading the way on that, is to incorporate the claims from the health plans, and we ought to cooperate on that so that we can build on the foundation that Better Health already has.
Mm-hmm. So does that mean on the payment model, though, you're willing to work with other health plans too?
Well, I think on the payment model, there are general principles, and there are a number of different ways to reform payment, from a care coordination payment, a PMPM payment, from shared savings on the back end, to bundled payments for some of the procedures that you talked about. I think that, but I don't think that there is a way around each of those payments being still within the contract of the payer with the provider.